Hello again, my name is Dr. Betty Dube, and this is the second part of the thyroid disorder series. Here's the captioning statement to remind you that the captioning is up to 80% accurate. Please pause the video to have a read. By the end of this session, you should be able to confidently describe the epidemiology, etiology, and pathophysiology of hyperthyroidism. You should also be able to identify signs, symptoms, and characteristics of hyperthyroidism, discuss the diagnosis pathway of hyperthyroidism, as well as the drugs used to treat hyperthyroidism. Just a quick recap here of the endocrine system and its relation to the thyroid gland. It's situated at the neck area. It produces thyroxine, and this is again just a reminder of how it's all connected to the master gland, the pituitary. I thought I'd also include the terminology here again to remind everyone of the terminology we use for this part of the series, and it's important that you familiarize yourself with these terminologies. When it comes to classification, we do have two main types of thyroid disease. So we have the hyperthyroidism and hypothyroidism. In this second part, I will be covering the hyperthyroidism. So what is hyperthyroidism? It's an excessive production of thyroid hormones and secretion by the thyroid gland itself. There's also thyrotoxicosis, which is a clinical syndrome that results from prolonged exposure to elevated thyroid hormone levels regardless of the source. So the distinction is important when evaluating the TFT, thyroid function test. So hyperthyroidism comes in different forms. So we have primary hyperthyroidism, we have overt primary hyperthyroidism, we have subclinical hyperthyroidism, and there's also thyrotoxicosis without hyperthyroidism. As you can see here, the TFTs can help us distinguish between the different kinds. So when you have overt primary hyperthyroidism, you have low TSH levels, but you have high TF4 and FT3s. In subclinical hyperthyroidism, the TSH is also low, but you have normal FT4s and FT3s. Again, this is not something we would expect you to commit to memory, but you should be able to analyze the lab results when you see them. So when it comes to the prevalence of hyperthyroidism, it's not uncommon, and it varies by sex, age, and geography. It affects around 0.7% of the European population, and many are undiagnosed, as listed here. Pregnancy is also a risk factor, and around 0.1 to 0.4 patients can be affected. Graves' orbitopathy is also quite uncommon. It's uncommon and it's an autoimmune condition, okay? And the incidence is again higher in women compared to men. So with regards to Graves' disease, we have up to 80% of the cases, and it's the most common cause of thyroid toxicosis. There's a systematic autoimmune disorder, which is mediated by the TRAbs, the thyroid-stimulating hormone receptor antibodies that stimulate the thyroid, the TSH receptor, leading to thyroid overgrowth and unregulated excessive production and secretion of thyroid hormone. It peaks between ages 30 to 50, and it's 10 times more common in women. Okay, an increased risk also if there's a family history of other autoimmune disorders such as type 1 diabetes, and that's why sometimes we see this presenting in our patients with type 1 diabetes. We also have toxic multinodular goiter, which is responsible for around 20% of cases, especially common in older adults in areas with historically low iodine intake. The nodules operate independently of normal feedback control, producing hormones even when thyroid stimulating hormone is low. Okay, so understanding the patterns helps you us predict the likely cause based on age, region, and clinical presentation. We also have the toxic thyroid adenoma, a single autonomously functioning nodule producing enough hormone to suppress TSH and silence the rest of the gland. And then we have a TSH secreting pituitary adenoma. It's rare but important, where TSH is inappropriately normal but high, and both the FT4 and FT3 are also high. Okay. Then we also have a pituitary thyroid hormone resistance syndrome, a rare condition caused by genetic mutations in the thyroid hormone receptor beta gene. Okay, a positive family history supports diagnosis. Usually the person is euthyroid but thyrotoxic symptoms may occur. Okay. So these rarer causes can make the clinical picture more complicated, but recognizing them early prevents misdiagnosis and inappropriate treatment. We also have drug-induced thyroid disorders. So these are external factors that can cause hyperthyroidism. Okay, so we have high concentration of the HCG. So this one is a rare gestational thyrotoxicosis. Okay. It's a benign and transient disorder seen in the first trimester of pregnancy, also known as gestational thyrotoxicosis, caused by stimulatory action of the placental beta HCG, the human chorionic gonadotropin, HCG hormone. There is a presence of thyroid autoimmunity, and it does not require specialist treatment. We also have iodine-induced hyperthyroidism, which can occur after exposure to iodine-rich supplements, iodinated contrast media, or even dietary kelp. So again, why that OTC herbal medication reconciliation information is important to capture each time you complete the medication reconciliation. Okay, and then we also have amiodarone-induced thyrotoxicosis, because iodine contains extremely high iodine levels. Amiodarone rather contains extremely high iodine levels and can trigger hormone overproduction in susceptible individuals. Because amiodarone has a long half-life, symptoms can persist long after drug is discontinued. So this is also important to capture that any medications that have been recently stopped. We also have extrathyroidal sources such as the ones listed here. We have the struma oravii, as well as the functional thyroid cancer metastasis. Another aspect also is the exogenous thyroid hormone. So if somebody takes excessive levothyroxine, for example, this can result into hyperthyroidism when that euthyroid, the balance, the dose is not appropriately calculated or given, and this can occur. Also, thyroid hormone may also be a constituent in some over-the-counter weight loss supplements. So it's also important for us to be educating our clients about the supplements that they take. Okay. So OTC thyroid support supplements may contain active thyroid hormones. So always remember to ask patients what they take aside from prescribed medications. Okay. So overtreatment can occur unintentionally. So risk factors. As I previously mentioned, women are affected 10 times more than men. Family history is important. About half of patients with Graves' disease report relatives with thyroid disease. Smoking stands out as a major modifiable risk factor and increases the risk of Graves' disease, and particularly Graves' orbitopathy. And it also worsens the outcomes. Autoimmune diseases also can occur and can be a cause. For example, postpartum thyroiditis is more common in individuals with type 1 diabetes. Okay. It's also important to remember that thyroid disorders are closely linked to an autoimmune dysfunction in the body. When it comes to symptoms, clinically, hyperthyroidism can present in a wide variety of ways, and sometimes the symptoms are easily mistaken for anxiety, menopause, or simple stress, depending on the patient's age and agenda, of course. Common symptoms include agitation, emotional lability, insomnia, palpitations, heat intolerance, sweating, weight loss despite increased appetite, diarrhea, and menstrual changes. Patients may also complain of muscle weakness, tremor, and general fatigue. Some presentation point to specific underlying causes. For example, a painful thyroid could suggest a subacute thyroiditis, while comprehensive symptoms like hoarseness or difficulty swallowing could indicate a large toxic goiter. So have a look at these photos on this slide here, just to give you an indication of the most common presenting symptoms of hyperthyroidism. In Graves' disease, we also sometimes do have an enlarged goiter. So Graves' disease, usually we have a symmetrically enlarged without nodules. So it enlarges both ways without the nodules. And then we also have the toxic multinodular goiter. We also have a toxic adenoma, subacute thyroiditis, and amiodarone-induced thyroiditis. So these vary in size as listed here. I also thought I've included some pictures here for you to have a look. I recommend that you pause the video to have another look here. Okay. Here is more pictures of what it could potentially present as. So these are examples of goiters, which simply refers to enlargement of the thyroid gland. It is not a diagnosis itself, but a sign that something has altered normal thyroid physiology. So notice a variation in the appearance on this slide. Some goiters are diffuse and symmetrical, often seen as in conditions like Graves' disease. Others are multinodular with obvious irregular lumps, typically in toxic multinodular goiter. Some are single dominant nodule, might indicate toxic adenoma, and very large goiters may cause visible neck swelling and even deviation of the trachea. So I encourage you to watch the video here to get a sense of how these may appear in clinical practice. Physical examination remains a vital skill in thyroid assessment. Again, depending on someone's scope of practice, but you could be at that position to flag somebody for a deeper assessment. Here we focus on Graves' eye disease, which is also called Graves' orbitopathy. It's an autoimmune inflammation process affecting the tissues behind the eyes. So typical symptoms include eye irritation and watering, gritty sensation, light sensitivity, eyelid swelling. And in more severe cases, you have a protrusion of the eyeballs and double vision, as seen here. So if you have a quick comparison between the normal and the Graves' disease presentation, it is important to remember that eye symptoms can persist even once the thyroid hormone levels normalize. So early recognition and referral to ophthalmology can make a big difference in the outcome. Again, we are best positioned to be signposting these patients. So Graves' orbitopathy is often asymmetrical and unilateral in about 15% of the population. It can appear before, during, or after the onset of hyperthyroidism, which means clinicians must maintain high index of suspicion. More than 90% of cases occur in people with Graves' disease, but the severity varies significantly. Signs may include lid retraction, swelling, redness, discomfort, and changes in appearance. Only a small percentage, around 2 to 5%, develop sight-threatening disease, but identifying changes early is essential. The key message here is to ask about eye symptoms in every patient with suspected hyperthyroidism and refer them promptly when needed. So when it comes to thyroid function tests, they are the cornerstone of diagnosis. So normal ranges are listed here. Please note the units, they are milliunits per liter. And then when you have hyperthyroidism that we're discussing in this part of the series, you have a low TSH or you have a high TF4, and this will require treatment. Okay. So it's important to make this distinction. When there's low TSH and high FT4, this is indicative of hyperthyroidism. Okay. The combination of TSH and FT4 usually gives you the diagnosis quickly. FT3 is particularly useful when evaluating the hyperthyroidism severity. So just in case you have a look at labs and wonder why did they only do one, they only did the FT4 rather than the FT4 and the FT3, and this will be the reason. Okay, so when it comes to diagnosis, so we have patient-reported symptoms, we have physical examination, and then we have blood tests, including TFTs and sometimes antibody tests as well. Because everybody's symptoms can look a little different. Some patients present very clinical features and others may show only subtle changes, such as mild fatigue, for example. And that's why all weight variation or mood symptoms always take a holistic view when you have this suspicion. So have a look here. Please pause the video and have a look at the best way to diagnose hyperthyroidism. Okay. When it comes to the thyroid antibodies, it helps to distinguish between autoimmune causes of thyroid diseases. So we have the thyroid peroxidase antibodies, typically raised in Hashimoto's thyroiditis and sometimes in Graves' disease. We also have the thyroglobulin antibodies, the TGABs, also associated with autoimmune hypothyroidism. And then we have the TSH receptor antibodies, which are a key marker of Graves' disease. A positive antibody test can help confirm the underlying cause, especially when symptoms or blood tests alone don't provide a clear picture. Okay. So when it comes to differential diagnosis between thyrotoxicosis and between hyperthyroidism and thyrotoxicosis, that is important. Remember, thyrotoxicosis can occur without hyperthyroidism, and this is could be the way it presents. So this for thyrotoxicosis without hypothyroidism to be diagnosed, measuring TSH receptor antibodies to confirm Graves' disease, as well as considering the tachypneium scanning of the thyroid gland if the antibodies are negative. So only consider ultrasound for adults with thyrotoxicosis if they have a palpable thyroid nodule. So that's again very diagnostic, but I thought I would include it here for completion. So the treatment of hyperthyroidism has three main treatment approaches. So we have the drugs, the thioamide drugs. Under this category, we have carbimazole and propranolol. Carbimazole is also known as methimazole also, but in the UK we know it as carbimazole. They inhibit thyroid hormone synthesis, and that's what we want because in hyperthyroidism we have too much of the thyroid hormone. We also have radioactive therapy, which destroys overreactive thyroid tissue, and also thyroid surgery is an option, either total or partial thyroidectomy. Okay. Patients with Graves' disease typically start with the medications. Carbimazole is the preferred drug, while the propranolol is reserved for particular situations such as first trimester of pregnancy. So it's not safe in carbimazole may not be safe in pregnancy. Okay. Then therapy can lead to remission in about 50% of patients with Graves' disease, but relapse is also common after stopping treatment. Then we have radioactive and surgery that are definitive options and used when medication is ineffective, poorly tolerated, or inappropriate. So it's important to note there. When you have a look at this slide here, you see that there's different approaches here. The doses are recommended, and once euthyroid is achieved, there must be close follow-up over time. So it's artwork, just like any other therapies. So when we move on to carbimazole on it as a drug, it is not active, so it's a prodrug, and it's converted to methimazole, the active compound. So it acts by inhibiting thyroid peroxidase, blocking iodination and coupling reactions needed to produce T3 and T4. So initial dose is between 20 to 60 milligrams per day, divided and titrated according to blood tests until the patient becomes euthyroid. Okay. There are two approaches to follow when it comes to maintenance dose. Here. So we have the maintenance regimen where you gradually reduce to a low daily dose. We have the block and replace where you continue a fixed dose of carbimazole and add in levothyroxine. Okay. That's so here the two ways. Please pause this video and have a read. So you could probably have come across either one of these, and those are both, just depends on the patient's presentation, and the duration of therapy can vary. But again, as it's been shown now, it can become a chronic condition. So most people end up with the lowest effective dose. When it comes to contraindications, hypersensitivity to the active substance, as well as serious pre-existing hematological conditions, and severe hepatic insufficiency. So again, means liver function tests will be important for these patients. Regular full blood counts may be important as well to make sure they do not get these adverse effects. Side effects are minor. We have pruritus. We also have a bit of muscle pain and a bit of GI upset. But there's also a serious side effect of bone marrow suppression. So close monitoring is important. Interactions, little are known, but potentially anticoagulants, theophylline, erythromycin. It's been said also any of the CYP450 enzyme inhibitors could interact with this drug. Okay, so I thought I'd include the mode of action here for completion, just to let you know this is what I was describing, that it inhibits the TPO, and both methimazole and propiuracil do the same there. So without that coupling, you cannot have the active form of the hormone. That's how you reduce the hormone overall. Then we move on to propiuracil as a drug. Again, it also inhibits thyroid peroxidase and peripheral deiodinase, so interferes with the oxygenation of the iodide ion. It's also an oral formulation. Initial dose around 300 as a single dose, and once euthyroid, this is tailored accordingly, and it varies per patient. Again, it's not a drug I've seen a lot in practice, but some of you may have come across. Contraindication, again, hypersensitivity to the drug. And when it comes to side effects, again, pruritus, abnormal hair loss, skin pigmentation, nausea, vomiting, and serious also can cause agranulocytosis, so blood monitoring is important. So this presents as ulcers, rashes, and a sore throat. There's big warnings and precautions when it comes to this. So if agranulocytosis symptoms develop, one must stop and seek immediate medical attention. A full blood count should be performed if there's a clinical evidence of infection. Okay. Then interactions again, iodine intake, theophylline and digitalis. So again, here supplementation of other herbals and supplement is important to be reviewed each time. So these medications have special counseling, but before I get into that, I thought I would include here just the snapshot of the treatments. The two drugs are listed here, the adverse effect, contraindications, cautions, and also surgeries listed here as a treatment. I have links to videos here, but I'll put those on the Moodle page. So when it comes to counseling, this is a crucial part of managing patients on the thioamides. Carbimazole must be given as a single daily dose. Duration of treatment should be anticipated. The block and replacement regimens must be explained. Adjuvant therapy must also be explained, as well as in reviewing the use of encouraging review use of other medications must be explained, and sometimes people tend to use beta blockers for symptomatic relief. Importantly, instruct patients to seek immediate medical help if they do develop sore throat, mouth ulcers, or fever, or any unusual fatigue, because these may be indicative of agranulocytosis. Okay, so patients should also understand that relapse may occur after treatment stops, and ongoing monitoring is essential. So that's also very important for most chronic conditions to always set that expectation for our patients. So adverse drug monitoring is important for this drug because they are at risk of bone marrow depression. Fatalities with carbimazole-induced granulocytosis have been reported, so it's quite important for this to be followed through. It occurs in one in 300 patients treated with these drugs. Mostly occurs in the first 6 weeks of treatment. Again, presents as a throat, mouth ulcer, and high fever. A differential white blood cell count, febrile illness, and pharyngitis in all patients that should be explored each time. And if this occurs, monitoring. The drug must be discontinued. So because of all these adverse drug reactions and the monitoring is essential when it comes to these medications. So TSH, FT4, and FT3 must be checked every 6 weeks until the TSH is normal, and then every 3 months. The full blood count and liver function if there's a clinical concern. I think in my previous practice, we used to do this at a minimum once a year, if not twice. So the next treatment for hyperthyroidism is radioactive iodine therapy. It's given as one oral dose. It's absorbed by the thyroid gland, inducing tissue-specific inflammation that leads to thyroid fibrosis and destruction of thyroid tissue over the next several months. Hypothyroidism usually occurs within 6 to 12 months. That means the person now will require to take lifelong levothyroxine treatment. Caution with this one is the dose of radiation used during radioactive iodine treatment is very low, but some precautions need to be taken after treatment. So first, they have to avoid prolonged close contact with children and pregnant women for about 3 weeks. Women should avoid getting pregnant for at least 6 months, and men should avoid fathering a child for at least 4 months. So these are very, very specific instructions the patient must be told of. And if any of you have worked in this kind of practice, it's important that the patients understand these timelines before they take this therapy. So it is contraindicated in pregnancy and lactation and in any active inflammatory Graves' ophthalmopathy. Okay, there's a video here from the British Thyroid Foundation for you to have a watch here. Again, matching the right therapy to the right patient is key, and the patient should be made aware and educated on the choices before they're made. Then another treatment for hyperthyroidism is a thyroidectomy, which is definitive but invasive treatment option. So it may be indicated for patients with very large goiters, severe eye disease where iodine is inappropriate, or intolerance to the antithyroid drugs. So again, there are some patients who might try the drugs, the oral drugs, but they may not just work for them, and this would be the best way to treat them. So before surgery, patients should be rendered as close to euthyroid as possible. In urgent cases, we use a combination of antithyroid drugs, beta blockers, and sometimes Lugol's iodine to bring them to your thyroid state. And then there's also a risk include increased some complications of surgery include anesthetic risk, bleeding, thromboembolic disease, and infection. And later complications of thyroidectomy include hypothyroidism and recurrent thyrotoxicosis. Again, there's a risk and benefit to the different treatment options here. Post-operatively, most patients require lifelong levothyroxine. I think maybe some of you are probably now thinking, oh, that's why we have so many. Maybe you see a large volume of levothyroxine prescriptions in your practice. This could be the reason. Okay. So just to summarize here, I've used the NG145 as a reference of how to best treat hyperthyroidism according to the NICE guidelines. So management and monitoring is listed here. Please take some moments to have a look. So there's the first line definitive treatment, and then there's monitoring and ongoing treatment. Both are important. I also thought I would quickly cover thyroiditis. Again, it's a different condition from Graves' hyperthyroidism. Okay, because in this thyroiditis, antithyroid drugs are ineffective since the patients usually have low production of new thyroid hormone. It's usually transient, but treatment is aimed by symptom control with beta blockers. So it's like and when you have subacute thyroiditis, just NSAIDs and systemic glucocorticoids can be used to help the pain and inflammation because it is There's an inflammation in the area. And beta blockers are recommended for any elderly with symptomatic thyrotoxicosis and any thyroxic patients with a resting heart rate of 90 beats per minute or with cardiovascular disease. Another aspect I'll quickly cover is the thyroid crisis, which can develop in any patient with significant untreated thyrotoxicosis, but is most common in those with severe Graves' disease. Can be triggered by infection, injury, trauma, anesthetic, surgery, or radioiodine. Signs and symptoms include rapid progressive tachycardia, so increased heart rate, muscle weakness, hyperthermia, sweating, and vomiting, compounding hypotension, and ensuring circulatory collapse. In addition, patients are extremely anxious and sometimes could be psychotic. So management here is, it is a medical emergency and requires high care. Supportive measures are important, and specific antithyroid therapy is required along to inhibit deiodination of T4 from T4 to T3. So we'll have high dose of proprauracil oral can be given with Lugol's iodine. IV glucocorticoids may be used to inhibit this as well as IV beta blockade is required. Propranolol is preferred because it inhibits deiodinase as well, so that to slow everything down and just manage those symptoms listed above. Treatment, again, it is a medical emergency, so immediate treatment includes addressing the symptoms and control the thyrotoxicosis. So we have a non-selective beta blockers, carbimazole or proprauracil, so either or. These will result in a euthyroid state within 6 weeks. And then we also have adjunctive treatment of cardiac disease or anxiety, sleepiness may be required. So it just depends on what symptoms the patient presents with, and that's how they'll be treated. So here are 2 videos that I'll need you to watch to just hear this story from the other side. So we have Ella's story and Ben's story. They both were diagnosed with hyperthyroidism. Again, just to remind you, so if you have any questions, please post on the discussion forum. Thank you for listening.